Hello, and welcome to the Center for Health Design's EBD Journal Club. Thank you so much for joining us. I'm Deborah Wingler, your host for today's session. I'm Vice President and Healthcare Research Lead for HKS. Before we begin today, I'd like to take care of some housekeeping details first. The purpose of the EBD Journal Club is to engage in the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes and apply it in the real world. Thank you to the Health Environment's Research and Design Journal for providing free access to the articles we review. If you have not already done so, we highly recommend subscribing to HERD. There is a discounted code for attendees to receive 20% off the subscription using the code HERD20. I'd also like to say thank you to today's EBD Journal Club sponsor, PACCRAFT. EBD Journal Clubs are formatted for a 15-minute presentation followed by a discussion. When you have a question, simply type it into the Q&A window. Access to the Q&A window is located on the bottom of your screen where the yellow arrow is pointing. On mobile devices, it may be located on the top of your screen. Continuing education units are available for this journal club from the AIA and from EDAC to receive credit for your presentation. For your participation, you can download the forms by clicking on the chat icon. There is a Dropbox link where you'll have access to the CEU forms in today's presentation slides. You can also type in the URL into your browser. For EDAC credit, complete the verification form and retain it for your records. You will need to report the credit to Scantron at the time of your renewal. For AIA credit, complete the verification quiz, purchase a CEU management fee for $12 from CHD's store, and submit the verification form to Catherine Enchetta. She'll upload the credits to your AIA account. You'll find Catherine's email included on the form. For those that require a certificate of completion, please fill out the link located in the chat pod and purchase a CEU management fee from the CHD store. A certificate will be emailed to you within 3 to 5 business days. I would like to now introduce you to the authors of the article we will be discussing today, Jennifer Wagner and Damon Greeley. Jennifer has dedicated her efforts and expertise to infection prevention program design through evidence-based science, research, education, and consulting. She has nearly 20 years of experience in environmental and clinical microbiology and is board certified in infection prevention and control. As managing partner of Onsite LLC, she is dedicated to improved clinical outcomes through data-driven solutions and has worked in numerous hospitals, both nationwide and internationally. Collaborative efforts to develop the use of environmental quality indicators for healthcare spaces have been validated in nearly 100 procedures and are published in the American Journal of Infection Control, the Journal of American College of Surgeons, ASHRAE Journal, and others. With Onsite's multidisciplinary team of clinicians, microbiologists, epidemiologists, healthcare engineers, and designers, she has worked to optimize the asepsis of critical spaces in hospitals and has developed the tools with over 100,000 data points to accurately predict the risk of microbial contamination in critical spaces in the built environment. Dr. Wagner's future endeavors continue to explore innovative solutions for successful and prudent improvement of infection prevention. We are delighted to have Jennifer here today. Damon is an aerobiological engineer and co-managing partner of Onsite LLC. For almost 30 years, he has led endeavors in research, planning, assessment, design, commissioning, infection prevention, and environmental monitoring of healthcare spaces and infrastructure systems. His vision is to continuously improve infection prevention in the healthcare operations environment through engaging innovation and creativity. As co-managing partner of Onsite LLC, he works closely with Dr. Wagner to investigate newer methodologies or technologies that improve infection control, coupled with best life cycle costs. He is Illuma Institute trained and facilities human-centered solutions that build consensus around the most advanced yet acceptable Maya approach. Damon has a professional engineering license and many credentials, of which I will butcher, but also including infection prevention and control via the Certified Board of Infection Prevention and Epidemiology. We are delighted as well to have Damon present. So thank you, Jennifer and Damon, for joining us today.
Well, good afternoon. And thank you, Deborah, for that introduction. Good morning to some of you who are on Pacific Coast time. And thank you for allowing us to present our research. We will give some brief acknowledgements to start. And then Dr. Wagner will provide a brief history on what environmental quality indicator research is. There will be two parts to a study we will go through. The first being external contamination that would be brought or carried or transferred into an ICU room during different modes of occupancy. And then the second part of the study will talk about contamination control within the ICU room itself, focused on a time during a procedure, whether it is emergency or bedside prescribed. Finally, we will briefly cover with just a few slides how we are using environmental quality indicator research to help with COVID-19 care, followed by questions and answers. Because we are studying harm, ultimately, of healthcare patients and now clinical staff, we have to address that there are many factors or multiple factors that contribute to these pathogens that are transferred either airborne or contact or some combination thereof. So we address these in different bins, and that includes the microbiology of the space, by which we will predominantly focus today's research on discussion. But there is also the physiology of the patient, the ventilation and cleaning of the rooms or spaces, and then also the people or processes and how the spaces are utilized. To do this, we had to have a cross-functional or multidisciplinary team that includes 3 MDs, 4 PhDs, 2 nurses, a microbiologist, infection preventionist, and a facilities and environmental engineers. I'll now turn it over to Dr. Wagner to discuss the brief history of environmental quality indicator research.
Thank you. Hi, everyone, and thank you for being here and allowing us to present this research. And so I'm going to start by telling you a little bit of the background of how we have learned over the years to predict a risk of contamination in any given space in a given time. We can do this both what we call in vivo and in vitro. And so in vivo meaning during a live procedure, and in vitro meaning basically a laboratory experiment, but using a real healthcare space. So in the schematic that you see on the left, this is an operating room. And you can see that there are different zones within this room. And the darker pink circles represent areas of the room in which we consistently find elevated levels of contamination. And when the circulating nurse comes in, or anyone in the space, and they move around trying to get ready for the surgery or the procedure or bringing the patient in, they come in contact with all these different areas of potential contamination. And this has the ability to either re-entrain this contamination or to cross-contaminate other areas of the space. And so what we endeavored to do was to find a way to understand how our environments can help to control and prevent this cross-contamination in the room in real time. And so what you see on the right-hand side is a typical team of experts that we have brought in every time we do one of these simulated scripted procedures. And these people come in, doctors, nurses, surgeons, medical staff from the hospital that we happen to be working in, and they conduct a simulated but real procedure in the room while we're collecting environmental data. So the only thing missing in this case is the patient, because we felt it was unethical to subject them to all the other equipment that we have to bring into the space. So what we have is a stake, and we actually do electrocautery and suturing and perform a real surgical procedure on the stake to simulate the contamination that would be in the room during actual procedures. This is a schematic of what our research looks like. Now, whether this is in vivo or in vitro, we've done both. We've done 97 different experiments, all scripted and repeatable. And what we've done is we've looked at different environmental parameters that we can measure in real time and get immediate results. So we're looking at particle counts, temperature, air velocity, CO2, humidity. We're also looking at movement within the room, door openings, occupancy, and all of these things. When we're doing our experiments, we are also able to collect microbial samples. And so, of course, it's the microbes in the space that are capable of causing the infection, whether it's a bacterial infection, a fungal infection, a viral infection. So the problem with these is that it's difficult to collect microbial samples and get immediate results. So in order to be predictive and proactive, we have come up with these experiments that have allowed us to create a way to visualize relative risk within a space. And so this here is a color-coded by sector within the room that tells us where our higher and lower levels of risk contamination for microbial contamination lies. So using over 100,000 data points, we've created an algorithm which is highly and significantly predictive of your risk for increased microbial contamination in the space. So looking at the right-hand side, this is a schematic of an operating room in which we conducted experiments during 2 total knee replacements. And what you see here is the variation between blue, green, red, and gray sectors, where blue is the best and gray is the worst. And worst meaning you have very little control of your environment in that space. There's little air movement, your temperatures may be too high or too low, your humidity's out of range. And what we did, you can see these blue triangles. We have one in a blue, one in green, one in red, and one in gray. And what you'll see on the next slide, these samples were actually collecting microbes in the space. And based on our risk prediction, this is exactly what we found. In your blue areas, you had statistically significantly fewer colony-forming units than you did in either green or red. And the same for the red versus the green versus the gray areas. And then interestingly as well, where we had placed microbial samplers in the green area, it was statistically significantly cleaner than it was in the red area. So basically what this is telling us is that our predictive model is correct. And it's correct 100% of the time. Now taking this research that we did in different spaces within healthcare, we wanted to look at the ICU in a couple of different ways. We wanted to look at it from external contamination, the hallway into the room, and then internal contamination. So first of all, going to look at this, multi-drug resistant organisms are very prevalent in ICUs. And most of these are part of the escape pathogens. So being just really, really difficult infections to treat because of the nature of the bacteria that are causing these infections. So in phase 1 of the ICU study, we were really interested in how can we design a procedure-ready room that will keep microbes from the hallway or contamination from the hallway from getting into the ICU. And we did this with 3 different controlled contaminants. The first one is a tracer gas, or SF6. The second one was the controlled contaminant of Baker's yeast, so a harmful microbe, harmless microbe. And the third one was DNA tracks. And so DNA tracks are small pieces of nucleic acid encapsulated in sugar molecules. And they're really intended to represent the ability of contamination to be aerosolized.
So in setting up the ICU for the different occupancy modes, we had 3 different modes. One was unoccupied, in which we had the supply CFM match the toilet CFM, which equated to 3 air changes within the room, and the room differential pressure was 0. We know that current codes and guidelines by FGI, which references ASHRAE 170, that ICU rooms have no requirement for pressure. The second mode was the occupied mode, in which we increased supply and return CFM to achieve 6 air changes, which is codified again as the requirement for occupancy in an ICU room. And the third mode was procedure mode, in which we increased the supply CFM a little bit less of an increase for the return, so that we had 15 air changes, which matches a procedure code guideline, and positive pressure being greater than 0.01 inches water column. We also added HEPA supply air filtration. This would make it a cleaner space and easier to measure our controlled contaminants that wouldn't necessarily be contaminated by other particles. And we did this using 2 predominant technologies for airflow control within ICU spaces today. One being a Venturi air valve, which comes from the laboratory industry. It is very fast responding and was designed to protect occupants that were using biosafety cabinets or fume hoods, protecting them from exposure. And we also used a VAV box, which is a butterfly damper control method for airflow.
So similarly to what we did with the operating room and some other healthcare spaces, we always have a script. And as this is an example of what the script looked like. And the reason for this is so that every person involved in the research does exactly the same thing every time, so that we have a comparable way to measure the variables that we're looking at. This is a schematic of what the patient ICU room looked like, and you can see at the bottom is a simulation of a hallway, and we have those controlled contaminants that are released at their release points within the hallway, so the tracer gas, the DNA tracks, and the yeast. And then we have, you can see the spaghetti diagram of the healthcare worker who would enter the room, walk around the room, perform a procedure at the side of the bed, and where the doors would be open. And then you can see where we're collecting the microbial samples, the tracer gas, and then the DNA tracks. These are the results of the tracer gas, and I'll walk you through it briefly. But you can see at 3 air changes per hour in the setback mode, there's detectable amounts of tracer gas within the room, more so with the VAV than with the Venturi. So at T equals 9, the physician enters the room with the patient, and the room ramps up to 6 air changes per hour. You can see the spike in the tracer gas is detected, but then is reduced as the time goes by. At T equals 24, we simulate the patient coding, and the door is opened, the code is triggered, and the air changes go up to 15. So now we're in procedure mode. And you can see how rapidly the 15 air changes brings that contamination in the room down to 0 eventually. Then at T equals 39, the patient is saved and the code is ended, and the air change rate goes back to the occupied mode of 6. And you can clearly see the spike in detection of contamination in the room. So looking at this, so graphically for the tracer gas, in-room tracer gas was significantly less detectable than in the room than in the hallway. And then the same thing for the Venturi valve versus the VAV. And we suspect that this is because the Venturi valve not only reacts faster, but it's very efficient at reacting to control the air in the space. Similarly, for the yeast, we found the same thing, that the microbes detected inside the room were statistically significantly fewer than those detected in the hallway. And we did find that with the Venturi valve, there was a percentage decrease. but it was not at this point significant. Now this is interesting too. So when we did the DNA tracks and we collected the molecules on microscope slides that were placed at a table that was intermediary between the point of release and the patient bed. And what we found is that there was no DNA detected at that intermediary table compared to the hallway, but that there was DNA detected at the patient bed as compared to the hallway, though it was significantly less. Our hypothesis for this was that this mode of transmission actually was more by the healthcare worker being contaminated when they came into the room and moved to the bed as opposed to the table. We then took this to phase 2. And so phase 2 was to look at in-room contamination and how we could control that. So very similar to the operating room, where the people in the space are the primary contributors. And what we're looking at in this case is basically human flora. And we're looking at it in 2 different ways. So we're using the surface air sampler with Petri dishes to collect bacteria that would come from the people in the space, from skin cells, from primarily Staphylococcus and some others that are very common on skin. And then we also use a BioTrack, which is a real-time total and viable particle counter, which uses ATP and bioluminescence to detect live organisms in the space.
As part of this, knowing that there was a procedure in the room, we wanted to add additional sensors and monitoring so that we could do, similar to our risk mapping in other procedure rooms, break the room down into multiple sectors, roughly 1 square meter, and understand the level of risks within each of the room. The room configuration was similar to part 1, except in this phase, we added a back table for instruments or other devices that would be used to assist the procedure. We still collected microbial samples. At this time, it was human flora. We had our BioTrack, which is our little blue squares there at both the patient bed, which is the sterile field on an operating side, and then at the back table. We used velocity, temperature measurement. We counted particles again. We also monitored temperature, pressure, and relative humidity. We did increase the air changes to above 20, so that now we would be compliant with an operating room of 20 air changes. We did have a positive offset as before, so we were positively pressured. And again, we held our airflow constant throughout the entire procedure study. Because we were using the risk mapping method, we decided to do the risk map for both unoccupied and occupied airflows in addition to the procedure. When we risk mapped the unoccupied space, we found it to be the very highest risk for contamination, which is understandable. We don't have many air changes and there is no positive pressure. One thing to note, that if you do employ a setback within your procedure spaces, and if there's a delay for starting, or if there's opportunities for staff to maybe cut through particular rooms to get to other sides of the suite, there is no protection that exists when the room is in that state. We also looked at the occupied mode, which only provided a slightly better condition around the patient bed. However, it was still in a very high risk area. And again, this would be understandable because we were only still 6 air changes and not positive pressure like a procedure operating room would be. And then finally, for the risk map of the procedure mode, we achieved the best conditions in just 2 sectors by the patient bed, which is where the supply air was placed for the room, which would be typical of an ICU, but a little bit of improvement around, but definitely the adjacent areas were still high risk, including the back table where we were setting out instruments that would be used for the procedure.
So this is the data that resulted from these experiments. And as you can see, we attempted to create a sterile field, a better, lower risk area for patients to have procedures performed. And using the surface air sampler, which is an active air sampler, we were able to quantify colony forming units per cubic meter. And you can see that in our sterile field, we had significantly fewer colony forming units than we did in the higher risk areas, such as the back table. And we also had settle plates, so where we just put out Petri dishes and allowed the microbes in the air to settle out. And we had a similar result where there were fewer microbes settling out onto these plates in the sterile field than there were at the back table. So using the real-time BioTrack total and viable particle counter, you see the same result, whereas there is consistently significantly fewer particles per cubic meter within the sterile field or within that area of better air control than there is outside of the sterile field at that back table. And you see that both with total particles as well as with the viable particles. The other parameters that we looked at explain why this is. So within that sterile field, you have a lower temperature, you have a higher velocity, and you have a higher humidity. And so these statistically significant other environmental parameters really do have a profound effect on the risk for microbial contamination in any given sector of any room at any given time. So the conclusions that we came to from the phase 1 and phase 2 of the ICU study. In phase 1, the ICU room was statistically cleaner than the hallway during all occupancy modes for all 3 of the controlled contaminants that were tested. We also concluded that the Venturi air valves kept the room statistically cleaner than the VAV for all of the tracer gas experiments. In phase 2, what we found is that the code-based air distribution really limits and doesn't allow us to provide an aseptic space for a procedure to occur around the bed. And the study also showed that the patient bed sterile field could be made better to support emergency or prescribed bedside procedure modes with an improved level of asepsis. So all of the statistics that were done in general throughout our experimentation is all analyzed by a medical statistician. Just information for you to know. I won't go through it.
Okay, I'll briefly go through how we're using EQI to support COVID-19 response. So as you can see in the upper left picture, that when a patient is infectious and releases or expels a bioaerosol, that aerosol is heading toward a pathway for exit within the room, right? We're trying to protect the healthcare workers. However, in this example, you can see that the healthcare worker is in that direct pathway. We do know that bioaerosols will travel further if the droplets evaporate and just the nuclei is exposed. And the specific humidity in the room, which is one of the parameters we measure, will affect that, and that is represented in the image below on the left. And then the image on the right would be as we applied this to one of our clients' infectious isolation rooms. And because of their particular limitations, they had to have a negative air pressure machine located in the hallway. By doing that, it created a contamination zone as the healthcare workers were entering and exiting the room, which might otherwise been perceived as safer spaces. We were also asked to look at a condition of intubating and extubating patients where there was a recommendation to use a HEPA recirculating unit. And because we know that healthcare workers are at greater risk when they are in and around the intubation, extubation process, the use of a HEPA recirculating unit made sense. We also know that HEPA is an effective filtration for the virus. What was not necessarily understood that we needed to study was there was a notion that if it was done in an operating room, that keeping the HEPA unit recirculating during a procedure might be a benefit. When we looked at the use of continuing to use the HEPA unit against the risk mapping, because a HEPA unit has a circulation pattern of its own, it was actually drawing air cross contamination of the sterile field and putting the patient at greater risk. So knowing that if the patient had COVID-19 and a surgical site infection would exponentially increase their risk for morbidity. The surveillance system architecture that exists today and technology is really quite phenomenal. The risk mapping can be done in digital displays. They can be in-room displays and dashboards. There are smart cameras that can identify any aberrants that you can think of from an infection prevention standpoint. This particular model was actually built 3 years ago, but it shows when a patient or a staff member does or does not have a mask on. To conclude, the processes that we used have been evidence-based. They are prospective, they are random, they are blinded for our clinical team. Our technical team does need to know what we're studying because we are controlling the instrumentation and the process for collection. We've built a statistical and analytical model for process improvement through risk reduction methodology. We also know it is implementable by bundles with quality control in an effort to achieve hardwiring and infection control and driving harm to zero or nearly zero. The additional sensors within the room, even without a camera, does create more of a digital hawthorn, so more information is known. And what is interesting about this is it provides information that was not known before and really reduces finger pointing and alternatively equips, engages the staff to solve the root causes of this by breaking down the silos. It's also benchmarking available, providing more evidence-based decisions. Each hospital does have to do monitoring, so there is a certain number of parameters that are already available for benchmarking, and of course you can add to that to improve your risk prediction. And finally, it helps by capturing the least controlled variables. If you think about temperature and pressure, pressure ranges have to be positive or negative, but there's no limit to how much or to what level of positive or negative. Relative humidity has quite a wide range. And all these variables, if they are kept controlled in a wider manner, have a less predictable and controllable outcome. We have had this research methodology applied to 7 different unique studies. They have all been published in peer-reviewed medical journals. These are some of the organizations that we've worked with or organizations that have come to us wanting data from our research to help improve evidence-based for their standards and guidelines. Thank you for your attendance. And we're open for questions.
Thank you so much, Jennifer and Damon. Your work is genuinely just fascinating and could not be more timely in where we find ourselves today. For those of you joining us, it's now your turn to ask questions to the authors. Please feel free to type in any questions you may have in the chat box, and we will try to answer them as best we can. And to kind of kick that off, Damon and Jennifer, I have a question for you quickly. which is, could you just kind of share with us, this is amazing, phenomenal research, but what are some of the greatest challenges that you've had in doing this research, this type of research?
I would say, from my perspective, the greatest challenge has been getting opportunities and people to allow us to come in and do the research in their hospitals, operating rooms, ICUs.
Yeah, I mean, we do know that access to healthcare spaces is very difficult. Jenny and I work a lot of nights and weekends because that's when those spaces are available. But it's important for us to do work in spaces that are regularly used for healthcare instead of laboratories.
Interesting. So one of our first questions is, did you calculate first cost of all interventions, allowing assessment of the return on investment for these installations?
We did. We actually had a national engineering firm based in Nashville, Tennessee, do an economic analysis for us. And that really was the purpose for the setback, so that we could pay for the additional technology to make the room ready for procedure. And the savings during setback is energy associated savings.
Excellent. So what was the time frame of this study?
Most of our studies take about 3 months, and this was no different. So we would begin with a experimental design phase where we would come up with all of our methodologies and processes, develop a budget. Of course, that budget would have to be approved. We would have to get access. We've gone to IRBs before, but because we typically don't work in and around patients, but we use as a proxy, we've never had to have an IRB approved.
Wow, okay, great. So Frank sent us a great question, so I'm going to kind of try and get through it. One of the traditional arguments for unidirectional airflow over the surgical site in the OR is the ability to maintain minimal airborne infection risk over the site. Does this agree with your research? And are there implications to the ICU airflow?
Yes, that does agree, and that is what we find, is that the more efficient and effective unidirectional downward airflow over the sterile field or the patient bed does very definitely reduce the risk of microbial contamination in that space.
Great, great, excellent. One of our other questions is, are there any other areas in the hospitals beside ICUs and ORs that you've conducted this study?
We've conducted the studies in pathology labs, and specifically pathology labs who have now adapted to COVID-19 testing. We've also done cellular therapy labs, pharmacies, and Jenny is working on a project for emergency department, treatment rooms, and waiting rooms.
Fantastic. When can we expect that to be out?
Gosh, probably.
Not putting you on the spot.
Yeah, I know, right? Probably about 6 months, I would think.
We will look forward to that. So another question, how is this research informing the FGI review cycle? Also, are there specific design recommendations which differ significantly that you have found from historical and code compliant approaches?
All right, so Jenny and I are both members of ASHRAE, and we serve on different committees within ASHRAE. We are asked to present updates to our research about every other year to the committees, and we leave that information open and available to them and help them assist with their processes for improvement.
Excellent.
I was going to add that the one thing that was very notable to us is with the ICU current requirements being 6 air changes and no pressure requirements, so they could be negative, neutral, or positive, would not be conducive or conducive enough to creating the best protective environment for the patients. And because we could adapt to a procedure mode, that air change or energy cost could be easily managed reasonably without adding or increasing infrastructure costs to do so.
Excellent. Excellent. Thank you. So this is interesting. What role do you see UVGI having in helping to keep the air sanitized in these types of spaces, if at all?
Well, one thing we know about our studies is we're studying how contamination happens in real time, which is transferred, right, from healthcare workers or the patient or vice versa. And we do know that UVGI would not be able to be employed because you're not allowed to occupy the room during those processes.
Absolutely. Another question is, how are your findings applied to everyday operations in a hospital? So can you kind of walk us through how these really inform quality improvement strategies within the hospital?
Yeah,
Jenny, do you want to share our case studies?
Sure. So we actually do have 3 case studies, which we're in the process of putting together, well, almost ready to submit the manuscript. But essentially, what we're able to do is go in and risk map any particular room and demonstrate where the areas of higher and lower risk are. And in one of the case studies, it involved some physical changes to the operating rooms that allowed for better airflow, addition of diffusers and things like that made it some physical environmental changes. And in others, it was simply a matter of where they were setting up their instruments. And so they were setting up their instruments in the perimeter of the room, and the instruments would lay out there for 30 minutes or more before the procedure would start. And in that case, we were able to show them that the area of the room they were setting it up in was uncontrolled and had a high risk. And so they merely adapted their protocols to set up their instruments on those back tables in cleaner, predictably cleaner areas within the room. And so in all 3 of the studies that we've done, we have found statistically significant reductions in surgical site infections before and after implementation of the intervention. So it's a broad range of what can be done with the information, and from anywhere from physical changes to behavioral changes.
That's fascinating. And I know when we were speaking a little bit about this prior, you were also talking just about how empowered the staff feel by having this additional information. Do you want to talk about that a little bit?
Sure. One of the circulators that we were working with told us that, of course, nobody wakes up in the morning, intentionally wanting to harm a patient. And in her case, she felt much more informed about what was happening in her room in real time, based on actions that were taken either by her or our staff that she didn't necessarily was aware of, such as vendors, right, that are coming in and providing information about how to use interventions or implants. So some of those processes were more informative as to risks that were occurring because of those.
That's excellent. Our next question is, how does the energy savings get reflected in the business case? What is the payback period using the setbacks? And are you able to estimate avoidable costs that might be associated with hospital acquired infections?
Yes, so the energy model, the savings we had was a payback within less than 1 year. And we looked at the infrastructure costs that included cooling, heating, humidification, dehumidification, as well as fan energy and the use of outside air. The cost avoidance is definitely a higher significant cost. Just using one of the case studies, over a 3-year period, we had avoided or helped the hospital avoid 41 surgical site infections that would have occurred had they stayed on the same trend. So if you look at a $50,000 to $100,000 cost per surgical site infection, that would have been their savings, or cost avoidance rather, over 3 years.
Wow. Wow, that's significant. So this is an interesting question. Is there any concern that if the room is designed to allow for procedural mode, then all other code requirements for MEP would be triggered and thus would burden the project cost? Have you encountered that argument?
We didn't feel that there were any implications to the code, and that is because bedside procedures are prescribed today. And, whether it's a trach or it's a PIC, or a code blue, right? Those things are happening today operationally and are not addressed by code officials. So by adding more air changes and positive pressure, we stayed, again, away from any code implications. We were only improving the space. So that was our approach.
Excellent. So as we're kind of wrapping up here, and we've got about 10 minutes left, and we've got a few housekeeping things to take care of, but in the next 3 minutes or so, we'd just really like to know your thoughts as we kind of embark on this new era, navigating COVID and then hopefully soon to be post-COVID. What do you think would be really helpful for the design community to know based on the work that you've been doing?
Jenny, you want to go first? Do you want me to?
Sure. I mean, I think that being mindful of how the environment can be used to control contamination and prevent contamination, I think is the best thing that we can do. And I mean, we really can use our environment to reduce contamination, to reduce who's in the path of contamination. And I think if you're thinking about an ICU room, think about where the air is entering and where it's leaving and how it could be directed away from healthcare workers. If we're talking about operating rooms, again, you want to make sure that sterile field and maybe even outside the sterile field has really very controlled airflow along with your temperatures and your humidities and all of those things. Maybe thinking about traffic patterns and how you can make the operating room efficient environmentally so that there are few or less need to go in and out of the doors. Things like that. And I mean, it might even be, I know some designers are adding diffusers over where they would set up a back instrument table. And so maybe, instead of expanding the array of the diffusers in the ceiling, they're just adding 1 or 2 more in strategic locations. So I think those are some things to consider. Damon, you want to add?
Yeah, just a footnote to what Jenny was saying, that by having a risk map and understanding what is happening at various points within the room, instead of just saying my room is compliant, but how can I make my room more effective aseptically, we found to be the most informative and beneficial to improve outcomes.
Awesome. Just kind of one final question for the two of you. We've in the chat are quite a few questions of when's the next publication. So, where do you see this going? And first of all, where do you see your research going in the next, let's say, couple of months in which we might be able to get some more information? But also, where do you hope to take it in the future?
Well, I can share that our next publication, if all goes well, will be in 8 weeks. But we can't share what, right? We don't want to taint the process. So, I think where we really want to go is is that awareness of what is happening at the room level in various sectors, because to improve, we know it's going to take everyone working together. You know, surgery, infection prevention, quality, safety, environmental, facilities, and we have proved through case studies that we can successfully accomplish that on behalf of the patients and now protecting the healthcare staff.
Excellent. Dr. Wagner, where would you like to see the research go moving forward?
Yeah, I mean, exactly that. And, you know, in addition, one of the things that we do is what we would sort of call product testing, where we've looked at anything from surgical attire to portable wheel-in HEPA units. You know, I mean, even some of the other technologies that are out there, such as vaporized hydrogen peroxide and all these, you know, there's a lot of technology that's coming out of this COVID-19 era. And we do have the tools to test the efficacy of these products and technologies. And I think that's something we would like to do too, to really get a great idea of what our options are for making a more aseptic environment.
Love it. Absolutely love it. That is so needed. So any product manufacturers out there, you know who to call to get your validated third-party testing. Just thank you again so much. This is truly amazing work, and we really appreciate your time sharing it with us. Just in closing, we would like to say thank you again to the Herd Journal for providing free access to the articles we discuss. Be sure to subscribe to the journal using HERD20 for your 20% off. Once again, thank you as well to Pat Kraft for sponsoring today's EBD Journal Club. Please be sure to check the events page on the center's website to see a list of upcoming events. Also to note, we are accepting submissions to the 2020 Healthcare Environment Awards. The Center, in partnership with Healthcare Design Magazine, is accepting entries to honor design solutions that move healthcare forward. Application deadline is July 15th. For more information about award categories, criteria, and recognition, please visit the Center's website. Webinars are a great, convenient way to learn, but if you really want to expand your knowledge on behavioral health, telemedicine, pediatrics, or aging, I strongly encourage you to consider attending one of the Center's virtual fall workshops starting in September. More information coming soon. Thank you very much, Jennifer and Damon, for sharing your research today. This concludes our event. We will leave the webinar open for another 15 minutes so that you can download the continuing education forums and slides from the chat box or typing the tiny URL into your browser. Thank you again for joining us, and have a good day.